When an area of the wall vessel gets too weak, it can tear. Tears in the aorta are caused by trauma, atherosclerosis, hypertension, poor connective tissue from age or Marfan's or Ehlers-Danlos syndrome, aneurysms, and smoking. There are two types of tears the aorta can experience. An aortic dissection is a tear of only the intima layer. The tear allows blood to rapidly enter in between the intima and media layers. Blood begins to tunnel up or down within the wall of the vessel, splitting the first two layers apart further and further. An aortic rupture is a complete tear of all three layers of aortic wall. A large aortic dissection or an aortic rupture can be quickly fatal for a patient if left untreated. When the aorta ruptures all three layers completely, the mortality rate is up to 90%. Blood that travels in between the vessel layers is blood loss. Lots of blood loss can cause hypotension and lead to shock. Nurses need to know how to recognize the signs and symptoms of a dissected or ruptured aorta. Your big clue is that the patient complains of sudden, severe, sharp pain. The patient will tell you that they have a tearing or ripping sensation. If the dissection or rupture is in the ascending aorta, the pain will be in the anterior chest. Notice how the aorta is close to the chest wall. The pain in the ascending aorta will radiate to the chest. If the dissection or rupture is in the descending aorta, the pain will be in the back between the scapula. Notice how the descending aorta is close to the back of the patient. The pain will be in the back. If the dissection or rupture is in the abdominal aorta, the pain will be in the abdomen or radiate to the groin or legs. An anterior rupture bleeds into the peritoneal cavity. This is very, very bad, because the bleeding is very fast. A posterior rupture is a bleed into the retroperitoneal cavity. This is also very bad, but not as bad as the anterior bleeding, because the surrounding tissues slow down the bleeding a little bit. Bleeding can cause bruising along the flank and back area. There can be a pulse deficit in radial and carotid pulses, and a greater than 20 millimeters of mercury difference in the systolic blood pressure between the arms. If there is aortic regurgitation, there will be a new murmur. When the blood loss becomes significant, the patient may show signs of hypovolemic shock, hypotension, sweating, nausea, and poor cardiac output, such as tired and syncopal symptoms, angina, and dyspnea. Diagnosis is made with a CAT scan with iodine contrast. This is the gold standard, but an MRA can also diagnose a dissection or rupture. After the diagnosis, the nurse will work on the number one goal: stop any more tearing. Pressure is causing the tear, so lowering the pressure will reduce the continuing tearing. The patient needs an ICU bed during this medical emergency. Nurses prevent more tearing by reducing blood pressure. First, try relieving pain. Next, lower the heart rate to less than 60. After the pain is relieved and the heart rate is less than 60, if the systolic blood pressure is still high or greater than 120, intervene to lower the blood pressure. The goal systolic blood pressure is less than 110 to 120. The patient needs their blood pressure to be the lowest blood pressure possible while maintaining adequate organ perfusion. Around 110 to 120 is ideal or lower. If the blood pressure is higher than this, then the dissection and tearing will continue.